So, uh, the pathologic characterization of rare tumor types, uh, it comes up into several issues as to what do we mean by characterization and what do we mean by rare. So, what I covered during the talk was the DNA analysis, RNA analysis, each of which shows that there are multiple mutations that are present within breast cancer. Unfortunately, many of these are non-targetable, and therefore uh, we do have a problem, unlike lung cancer, where we can divide the cancer into 20 different subtypes and have specific therapies. The second point is RNA analysis has typically shown that every tumor is a unique tumor in terms of having a unique RNA fingerprint. So then the question is, how do we define rare subtypes? And typically, we kind of end up using histology as the major categorization factor. The problem, of course, with histology is uh, it is subjective. We as pathologists trained for several years to look down the microscope and learn from our seniors how each of those tumors are classified. But my 90% or my 80% may not be your 80%. Mine classification may not be similar to yours. And that's the reason a subjectivity comes up. So, what I tried to talk about was A, that the subjectivity exists, and B, there are multiple tools one can use to decrease subjectivity. For example, we can use clinical data, and the example I used there was the inflammatory breast cancer example, where one can use clinical pathologic and radiologic findings together to come together and make the diagnosis. I also use the example of tubular carcinoma, where 90% tubule is required. And the question is, what is 90%? For that matter, what is your tubule? And I presented some data from literature about heterogeneity in people or non-concordance between pathologists in terms of classifying or recognizing what a tubule is, how much component of a metaplastic tumor should be metaplastic. So all of those things become problem. But apart from that, we have clinical tools, we have immunohistochemistry and molecular tools. And the example I used was adenoid cystic carcinoma, where we have a very specific alteration that you can detect by FISH. And then there are other examples that I showed in the talk where we do not really have a major ability morphologically. So we could use AI. And then the example I showed there was lobular carcinoma with E-cadherin mutations, and how those mutations have been used to train AI in order to get a more consistent diagnosis. So those are the kind of things I discussed during that talk.